So once again, welcome to the Primary Care Phase Investment Programme, Exploring Patient Experiences in Primary Care Improvement. My name is Peter Cawston. I'll be chairing the webinar. Just a couple of housekeeping things. The session is being recorded. Cameras and mics have been disabled. For those that are camera shy, you won't appear on the recording. We do encourage you to use the chat and the Q&A function. They will not be visible during the recording, but we will refer to them later on in the session, some of the chat and some of the questions. So if you have a question for the panel later on, then we'd encourage you to use the Q&A box, which you'll find on your screen. And if you have a general comment or contribution to make to the discussion, please feel free to use the chat function, and that will be being monitored throughout the webinar. So my name is Peter Cawston. I'm a GP and I'm with the clinical faculty of his primary care improvement portfolio. Really delighted to have so many people joining this webinar, and I'm really excited about what we're going to be discussing. Just a couple of sort of limitations that we need to point out. Obviously, we'll answer as many questions as possible during the discussion section at the end. We won't be able to get through all of the questions, but there will be a resource created at the end, which will look at any questions that aren't addressed during the discussion. So I would encourage you, please, to use the Q&A function to put down any questions that you'd like discussed. We'll either pick them up in the discussion section or we'll answer them later in a resource to be sent out. Just to comment on what kind of questions we won't be able to tackle. Obviously, contextual factors, funding, policies have a huge impact on patient experience. But any questions on contractual matters or Scottish Government policy will be kind of out with the remit of the webinar, so we won't be able to discuss them. Let's move on then. I'm really delighted to welcome our speakers. We'll give you a bit more information about each one when they come to speak, but we have Dr. Marianne McCallan, Kieran McElveen, Alice McGuire and Stacey McGrath, and we're ever so delighted to have them with us to share their experience and expertise with us. The webinar is a game of three halves. This is part of the Primary Care Phase Investment Programme. So in the centre of it, we'll have a discussion from Kieran, Alison and Stacey about discovery conversations and the primary care journey in the PCPIP. But before that, the webinar is going to look at the kind of people who perhaps don't take part in efforts to explore patient experience, particularly those patients who have very complex experiences of primary care, very complex conditions, and tend to be excluded from having their experiences looked at. And so we're going to be looking particularly at that group of patients first. Then we'll come on to the discovery conversations in the primary care phase investment programme. And then finally, we'll have a section to look at challenges and opportunities to improve patient journeys. Before we get stuck into it, I'd just like us to take a second to reflect. And a poll is going to come up. I just would like you to start putting in any words that come to mind when you think about patient experiences in primary care. If you could just put in any word or a couple of words at a time and then submit as many as you like, just to get a feel for what it is that we feel as an audience and as participants about what patient experience in primary care means. So the kind of words coming up just now are frustration, long waits, disjointed is coming up popular, scramble, I like that word, that's good, inconsistent, waiting times, challenges to reach, disillusioned is coming up, and frustration. I'm not sure if that's staff frustration or patient frustration or probably both. Confusion, inconsistent, challenging to reach, online system, service focused, influenced by media, Amazon effect, unrealistic expectations, getting worse. So I think this gives a picture of where we're coming from, and I guess some of the interest in this session has been our own sense of perhaps frustration and disjointedment and difficulties in providing a service which provides a good patient experience. So thank you very much for your submissions to that. We'll have a reflection from the panel at the end with their thoughts on your contributions. Before we go to Dr. Marianne McCallum, we're going to watch a very short video clip which is called Robert's Story. Now this is a very innovative piece of work which comes out of quite in-depth investigation of patient experiences, particularly of people living with multiple long-term conditions. It's a collaboration between University of Liverpool and University of Glasgow, and the video itself has been put together by Dr. Nick Dixon as a composite of patient experiences. So rather than having a patient come to us to talk about their experience, we decided we'd show a video clip of Robert, who is a composite coming out of a lot of research in people who tend not to have their voices heard terribly much in terms of patient experiences. So we're confident the technology will work, and we hope that you find this video clip interesting.
And you're still going to your group?
Aye, volunteering there too, when I feel up to it.
Good, good. Okay, so here are your prescriptions. Take these 3 times a day with food, these ones once a day in the morning, and you have a mental health appointment at Gartnavel, and you have to see the gastro team at the Queen Elizabeth.
So my name's Robert. I'm 45 and I'm in recovery. I've got asthma and problems with my stomach and chronic pain, and I've got depression. It's been a long road to get here, but I'm finally taking charge of my own health. Except, it's not that simple. Take these pills with food. It isn't that easy when I have to choose between the bus fare and breakfast. If I don't have the change, I can't get across town to the hospital. Pain means I never seem to get a good sleep at night, so I'm knackered all the time, and I miss things. Medications, meetings, lifelines. Things can fall apart so quickly. Sometimes it's all too much.
Managing complex conditions requires a lot of effort for everyone.
But for folk like me, who might not have a lot of resources,
it can be almost impossible to juggle medications, appointments, and self-care.
It's not that I don't want to get better, it's just that sometimes I need extra help. Things aren't designed for people with tough lives and different health problems. It'll take time to change the system, but I hope that somehow we can find solutions that work for everyone, including me.
So I hope you found that video interesting and thoughtful, and what I'd be really keen on is if folk would perhaps put some reactions in the chat as we go on to the next section, and we'll pick up on your reactions in the video in the panel section at the end. So I'd like to hand over now to Dr. Marianne McCallum. Marianne is an academic GP based at Glasgow University. She's completed a PhD exploring how individual and community factors influence self-management of multimorbidity in the context of poverty. Her research focuses on the role of primary care in reducing inequalities in health, particularly for those with multiple long-term conditions. So I'd just like to hand over to Marianne now.
So hi, good afternoon. My name's Marianne. I am a GP. As Peter said, I work 2 days a week in Clydebank, and I'm an academic GP, which means I do research as well. And as Peter says, my research interest is really around health inequalities. And my job just now is to try and look at this huge topic of patient experience and look at some of the higher kind of things that we maybe don't often have time to take back and think about on a daily basis because we're so busy at the coalface. And inevitably it will have a health inequalities slant because that's the lens I take to most of my work. But you could just as easily put the lens of rural communities or your local communities, hopefully, as I carry on. So, 2 ticks, there we go. There we go. Sorry, that was me. So the first thing that I'm keen to focus on is the system, and is recognizing that a lot of understanding patient experience is out with our personal control. I had an epiphany in the middle of COVID when I realized that I was so stressed in the middle of an incredibly busy phone surgery, and was being really doctor-centered to just try and get through that list of people, and had a real epiphany of like, do you know what? I was being really hard on myself, and I was like, nobody could work in a person-centered way in this system. And I think traditionally, I know not everyone in this call is a clinician, but I think traditionally when this comes up, what happens is a lot of hardworking clinicians just feel bad and think, right, I've got to try better. But I think a key thing, and particularly with HES and looking at quality improvement, is actually looking at how do we design systems that actually fit around people who need them rather than the people who work in them, which is what we typically do. And so I've got a couple of key points that I'm just going to make at the start, and actually you can listen to them and not really listen to the rest if you want, because they pretty much cover everything. So the first thing is one of my bugbears, is recognizing that our health systems are primarily designed by healthy people for healthy people. And so we design systems that would work for us, and we often don't actually really consult the patients or the people who need to use them. And when those people struggle to engage with what we've set up, we tend to label them as non-engagers, and put the issue with them engaging on them rather than maybe on the system that we've designed. Secondly, I've been doing a lot of talks on a variety of things, and I feel it keeps coming back to this key thing, this key bread and butter of general practice. And you'll probably all know the famous thing that Bill Clinton's elections advisor said to him all those years ago: it's the economy, stupid. And when he was trying to work out what are the key things to getting elected, when it comes to patient experience, when it comes to general practice, when it comes to health inequalities, when it comes to improving outcomes, I genuinely am becoming more and more convinced that we really need to be recognizing the importance of relationship. It is so critical, and I hope by the end of this talk I will have made clear to you why it is particularly critical for certain populations. Finally, the key thing, and particularly in a health improvement context, we need to recognise that many of the barriers that people experience are not necessarily seen, or they might be seen by the people and other people within that community, but they won't necessarily be seen by the health system. And so if all we do is measure what we already see and what we already do, then we might inadvertently widen inequalities. We might not actually be focusing on the things that matter most to our patients. And so the final plea is to ask people to sort of step back and think about the people they're not seeing, think about the people they're not, think about things that we're maybe not seeing, but that are actually the key drivers in how people are experiencing our service. So just quickly, I want to talk about relational care, and that's the importance of us having good quality relationships and the importance of continuity of relationships. For myself as a GP, that obviously is generally patient to patient. For some of you, that may be in your CTAC centres or people that you are reviewing, doing your meds review. And why is it important? Because we know in general practice, it reduces mortality, it reduces hospitalisation, increases patient trust, and there's just multiple other benefits. There's a whole heap of resources there, but essentially, if this was a drug, we would be putting it in the water. And yet, I think we are at risk in an overstretched, under-resourced health system of forgetting the absolute key importance of this. And the reason it's an issue is once relational care goes, everything tends to fall with it. So this is something I think we need to fight for. But it's not just that individual one-on-one relationship that's important. Community is important as well. And I'm going to mention a quite complex social science theory called habitus. And habitus was designed by someone called, or explained by someone called Bourdieu, back in the 60s, 70s. And he basically, habitus is basically the internalization of external factors, which I realise sounds really geeky and weird. Essentially, what I'm going to do is use the example of a ceilidh. So if you, a few months ago, I was at a conference and I was chatting to people from Southampton. Suddenly this music started and half the room got up and started to dance, all doing the same moves. And these two girls were like, what is going on? Whereas I was like, this is completely normal. I grew up in the west of Scotland. I had to suffer social dancing. For me, people getting up and doing the gay Gordons is a completely normal thing to do. And yet you don't realise what's normal for you until you're speaking to people for whom it's completely weird. And to further this on and put it in a healthcare context, let's say the government decides that to improve physical activity, they're going to fund and roll out ceilidhs all across the UK. You don't need to have a PhD in health research to recognise that that is going to preferentially affect some communities more than others. And the people who are going to benefit the most are the people who already know this, have been doing it for years. Now, there may be people down south who are going to be willing to go along and give it a go. But unless you resource those ceilidhs with people to explain what to do, people might go along to them, but not really fully benefit. And I know that sounds trite and really simple and a bit silly, but actually all the time we roll out healthcare interventions universally across the population, and we don't really ask, does this actually fit with the people that we're trying to reach? And in my PhD, I found that community experiences were really important in how people engaged with healthcare. So the people that I work with had certain key experiences. They were known within their community, and that made their community a safe place. They knew people, they knew their neighbours, and people knew them. But they were also known as being from their experience, their community. And this is a community experiencing high socioeconomic deprivation. There was a widespread experience of stigma that made people feel very wary of going into situations where they could be judged. It made places out with their community almost feel unsafe. And finally, there was this universal experience of none of the systems working. And that wasn't just health, that was social care, education. And it wasn't just that it didn't work for them, it didn't work for anybody that they knew. And the key reason why this is important for us is that if you live in a community that experiences this, it fundamentally shifts the way you approach statutory services. And so you don't see professionals as safe and good people. And what I found is that these negative experiences in particular cause people to do two things. First of all, they disengaged, they just sat and listened and smiled and then went away and didn't do anything they were told to do, or they got angry and got barred, neither of which helped them to engage with the health system and help them to improve their capacity to manage their own health. And the critical thing about this whole process is that it was widely unseen by the health system. However, the other thing that I found, and this is me bringing it all the way back to relational care, was where people experienced high quality relational care from their primary care practitioner, it shifted primary care from a system that didn't work to one that was for them. And it was really important in enhancing capacity to manage. And so I just really want to sort of underline that person-centred care, relational care is important. It's particularly important in communities, in this community, but I suspect if I did the same work in other communities, there would be other shared experiences and other unseen things going on that are actually shifting how people see care. And person-centred care is a key part of solving that problem. So for those of you who are interested, Peter helped co-author a report by the GPs at the Deep End specifically looking at relational care with different levers at different levels in terms of how we might improve that. I'm now going to quickly talk about two theories, and what I'm looking to do here is to kind of give you a lens with which you can go back to your own context and start to think about some of this in maybe a more practical way that might give you sort of solutions or ways to think through what it is you're doing with your patients. So burden of treatment theory essentially states that you have something called treatment burden. This is the work that we as clinicians give our patients to do. And you have something called capacity, and this is the capacity people have to carry that work out. Now, the key thing about capacity is that it can depend on all kinds of things. It can depend on whether you've got access to transport. It can depend on whether you've got money to buy things. But also, as well as individual factors, these community factors come into play. So do you live somewhere really with lots of shops and lots of access to fresh fruits? Or do you live in a community where I used to work, where access to the supermarket was over 2 miles away with no buses that went to it, but there were these slightly dubious ice cream vans that went around the community and sold cheap noodles, other cheap processed food, and I suspect other illegal things. If you live in one of those communities, then actually it's the easy choice is the unhealthy choice. And when you are overwhelmed by everything else that's going on, that's where it will go to. And the reason I bring this up is that I genuinely believe a big part of the reasons that we have ongoing inequalities in our healthcare system is partly our system and also us professionals' unwillingness to actually look at this factor of capacity. I think we so rarely stop and say, can this person actually do what I'm asking them to do? And the second brief theory I want to run through is something called candidacy. So just bear with me. So this is basically a theory, if we start in that top box, of how people get involved with and interact with the health service. The first thing they need to do is called identification. They need to recognise that they need the healthcare service. So things like health literacy, understanding that coughing up, maybe coughing up blood or something else is something that is actually really important that you see the GP with. And people need to recognise that or identify themselves as a candidate to require health care. And then once they realise they need healthcare, they need to navigate where they go. And that I think we all recognise is getting much, much more difficult. And that's very much influenced by their health literacy, their general literacy, whether they speak English as a first language or not. Then if they manage to work out where they want to go, they then actually need to get to the service. And all kinds of things can impact that. And one of those things I was saying about relational care, where it's really important, is for people who've maybe got issues with trust or are from a community, like I explained, where none of the systems work and professionals are not safe people, like actually going to a health service, going to a new building, meeting someone you've never met before, those can be incredibly challenging things for some people, often through no fault of their own. That's the next service. And that is affected by something we call permeability. So how easy do we make it for people to get to? So A&E, for example, is your very permeable service, going right up to across the health service spectrum, right up to your really super specialist clinic that you can only get there if another consultant refers you to. So how the sort of barriers we put in place. Then when you get to the service, you go through this process called adjudication, where you need to explain why you're there, which can be very difficult for people to kind of articulate what's going on, particularly if there's a lot of other stuff going on. And then you have a health professional who then judges what to do with your symptoms. And then they offer further services, or you basically refuse them. And again, as we go through each of these things, what I'm kind of trying to say is that we so often think about this from our own perspective, from our professional perspective. We create patient pathways where people very happily go along from one thing to the next. But actually, from the patient perspective, some of these things can be really difficult, and some of them can be difficult in ways that may not be immediately obvious for us, depending on the background or experience that we have. So I'm just going to finish off by going through something called missingness, which I think some of you will have heard of before. And missingness is essentially groups of people who miss multiple appointments. So not just someone who had too many things on and forgot it, but some people who miss multiple appointments. And this is important because they're more likely to die, especially if they've got mental health illnesses. They're more likely to use NHS resources. And we also recognise that there's a strong association with this group and other markers of social exclusion. So this is a group of people, normally quite highly socially excluded, who are struggling completely to attend the system that we've set up. And this is because, and it's going back to some of that stuff I was saying about for people for whom relationships have never been safe, relational care is actually really difficult, and it can take them a lot of time to trust. They might not feel appointments are for them. They feel appointments are sites of poor communication where they feel they experience stigma. There's power imbalances. People are exposed to competing demands, priorities, and urgencies, things that, like, as Robert was saying, are more important than getting to the health appointment for good reasons. They might struggle with travel and mobility, and there's not flexibility in when, where, and most importantly, with whom appointments take place. So that was a very brief run through on a huge topic, but if I go back to my main conclusions, it's relationship stupid. Putting relational care at the heart of what we do is really, really important. We need to centre the patient perspective. If the only people deciding and designing services are professionals, then we need to recognise that we're going to continue to have services that do not work for the people who need them the most. We need to recognise how community shapes experience and be willing to adapt and fit around that, and use the stuff that we have, like relational care, to impact that. I personally think we need to consider capacity and work, and I think that's a really helpful lens for looking at our current systems and trying to think of ways in which we can improve. And finally, we need to think about this group of patients who are currently missing. Thank you.
Thank you, Marianne.
Sorry.
Hi, everyone. I'm Keir McElveen, and I've been supporting the Primary Care Phase Investment Programme with a focus on understanding how we involve patients and their experiences as a part of improving care. As part of the programme, demonstrator sites were asked to agree to an Equality and Fairer Scotland impact assessment, and through their Memorandum of Understanding, agree to include patient engagement in their planning. That focus on patient experience has come through in different ways, from interviews carried out as part of the evaluation to local conversations about how services are working for the programme and the people using them. To support this at a local level, we encourage sites to use the Care Experience Improvement Model, or more easily known CEIM. In this context, this is care in primary care and not people who have been in care and have experience of care. CEIM is a simple way for teams to listen to what people are saying and try out small changes in response. But today we're going to focus on how that's worked in practice. I'll give a short introduction to CEIM and why it was offered as part of the PCPIP programme, and then you'll hear from both Alice and Stacey, who have played a key role in implementing within their demonstrator sites and will share what it's looked like in real life settings. So why the Care Experience Improvement Model? We encourage the demonstrator sites to use CEIM because it offered a clear and practical way to act on what matters to people. It's built around real stories rather than scores, and it helps teams to reflect, test, and learn in a way that fits with local improvement. In PCPIP, many teams were already testing small changes and working in flexible, responsive ways, so naturally CEIM matched that approach. It's also adaptable. It can be used in clinical settings like CTAC, in admin processes, or really in any area where teams want to improve based on lived experience. But most importantly, it supports teams to move from listening to doing, and this is what made it such a natural fit for the wider programme of PCPIP. So what is CEIM? Well, firstly, it starts with noticing. That could be a story, a comment, or a bit of feedback that sticks in your mind. It might come from a chat with a patient, a complaint, or even just an offhand remark about how does it feel for that person to be on the receiving end of the service. The next stage we have is reflecting. Just taking a pause to ask what mattered most in that experience. What does it tell us about what it's like to actually use the service? And from there, we're going to look to reprioritise. We're not trying to fix everything. We're just picking one small specific thing that we can actually do something about. We're going to ask ourselves here, what could we try that might make a difference to this person? After that, we're going to look to test a change. It might be a tweak to the process, the way we communicate, or even how someone is welcomed into the service. It should be safe, manageable, and easy to try at this stage. Once we've tried something, we want to take a step back and ask, did it actually make a difference? It's about pausing to look at the impact here. What changed and what have we learned from this? And finally, the last part of our journey is about implementing and spreading what works. Making the change a part of how we do things, or sharing the learning so that others can build on it. The whole point of this is to keep things focused on the people that are using the services. CEIM is about turning real experiences into small practical improvements. In order to bring that to life, I'm going to be joined by Alice and Stacey, who have been putting that into action locally in their demonstrator sites. Firstly, Alice has been closely involved in planning and developing the CTAC model in NHS Borders, and she's going to share her experience on how patient experience can be considered and built in from the start. So thank you for joining us today, Alice. Would you be able to share why it was important to bring patient experience in from the beginning, rather than waiting until the services were up and running?
Absolutely. So I think in primary care, even quite small changes that we're making, and the changes we were making weren't that small, can really impact on thousands of people. And if we don't understand what matters to patients right from the start, we can end up building something which looks really great on paper and which everybody in the room thinks is going to work brilliantly and then doesn't work. And in the worst case scenario, you can even create some barriers to people to receiving the care that they need. So getting in there early, having early and planned engagement really let us reach out and spend time with groups that might otherwise have been overlooked. There are always some people who are very eager to engage and keen to engage, and we wanted to engage with those, obviously, because those people are amazing, but also to reach out to groups that are less engaged with us so we can understand their needs. I think, as we've said before, it's really important that we consider issues that we as health professionals haven't maybe thought of, and we can design accordingly. I also find that people are more likely to engage and support services when they see their voices in them. It's really good for them to feel a bit of ownership of the services and to feel like they're being heard. It not only helps us design things, but it also helps us to kind of sell it to people, I guess, a little bit in the end, and to help them feel more a part of the service. I'd also say that while patient engagement from the start, it does take more time at the start, it often really speeds things up at the end. It prevents us having to do redesigns when changes are harder to make or being stuck with a service that isn't really working the best for some of our more vulnerable patients.
Thank you, Alice. Could you talk us through a bit about how you got the team ready to use CEIM and how you built it into the early planning for CTAC and NHS Borders?
Absolutely. We were really lucky in the Borders in that our team was engaged right from the start and really recognised the value of this approach. So I worked initially with some of the senior nurses involved who had experience and interest in qualitative research, and we did draw heavily from the templates and the materials available on the HIS website. So half the work was already done in that. I'd say one of the hardest things we came across was developing open-ended, non-leading questions. And we really went around the houses, and I kept going, oh my goodness, no, that is leading. So we kept them very simple with just a few questions about how people felt or how people found things, with some prompts in case people needed a bit of a prompt to keep talking, although that hasn't been a problem so far in the interviews. The next thing was recruiting patients. We had a good think about how we could get people in. So how we've gone about for our first round of interviews, which is getting our baseline before we make major changes, is that we're selecting clinics on a particular day, and we invite everybody who attends that clinic to see if they would like to or would be open to having a CEIM interview. in the future, we will focus more on particular groups, for example, by working with patient organisations that we worked with during the Equality Human Rights Impact Assessment, or we can target particular clinics which are treating particular conditions if we want to get in there. We also found that with doing the interviews, it was helpful to have two people there, one to scribe and one to ask questions. So initially our senior nurses have been doing those interviews, but we do want to start expanding those out and because we want other perspectives from the scribes as well. So we want to start bringing in healthcare support workers, receptionists and so forth to be part of these interviews. And I guess what we're exploring at the moment, because we're still quite early in it, is how we're going to share this anonymized feedback and any changes we've made as a result of that back into the public. So will we have like a section on our website where people can go and see what we've done?
Brilliant, thank you, Alice. And just lastly, what would you say to others designing new services, and how can they build in lived experience from the start?
So I've always found that if you don't make a part of your plan right from the start, and have protected time for it, or as protected as anything ever is for this, it can be seen as an optional extra and drop off. So I think like having it right there from the start and being seen as part of the service and part of the job is really important. I think being inclusive is really important because, as I said earlier, there are always people who are more engaged and really kind of jumping up and down to be engaged, and they are fantastic. But you also want to be able to reach out to really diverse groups of people and hear from everybody. There's just some really basic things like keeping language plain. You want to have everything accessible to patients when you're talking to them. Having two people to get to is really helpful, and closing the loop, giving feedback back to patients is important.
Brilliant, thanks very much for sharing that with us today, Alice. I'm also going to be joined by Stacey McGrath. Stacey's a practice educator with NHS Ayrshire and Arran, and Stacey's had a key role in the use of CEIM within the CTAC Hub service and the wound care service. And she'll talk us through today about how they gathered patient experience and what they learned about and how that has shaped their work within the service. Stacey, can you tell us a bit about how you introduced CEIM in those services and what helped you and the team get started with discovery conversations?
Yeah, sure. So initially we had actually gathered data on a small change that we'd implemented. We started using a cluster approach to make sure that patients didn't miss out on treatment for wound care or compression due to staff absence. So the data that we gathered in this was really successful. It showed 100%, no patient missed an appointment. They were able to attend another GP practice within the cluster for that. So that was amazing, but it didn't really tell us much other than they didn't miss their appointment. We wanted to know how they felt, what was their experience. We had used CEIM conversations, as you said, in our hub setting in Ayr, whereas a practice educator team, we had all carried out these conversations with patients in the past. So that really helped us to establish, like Alice was saying as well, non-leading questions. Note-taking as well was really important, and making sure we'd taken down exactly what all these patients felt about the experience as a whole.
Thanks, Stacey. And once you gathered the feedback, how did you start to make sense of it, and what did you begin to notice about the stories?
So first of all, we collated all the notes together that we'd taken, studied them, reflected on it, and started to try and theme the comments patients had made. Now, this allowed us to obviously see comparisons, but we could also see sort of common issues or concerns that had arisen as well, and most importantly, what was important to patients. The main sort of thing that we got from it was what we as a team had deemed as important when establishing this change idea was logistics, was making sure the patient was seen, there was no break in their treatment plan, they had that appointment, that was deemed as successful. But actually what we got from the feedback from the patients was quite different. Main themes were they were happy that we're continuing their treatment, but there was a lot of anxiety at attending a different location, which was something we hadn't considered, I'll say, and relief when they attended that new location, that they were expected, that they were known, they had a time, and the staff knew who they were here to see. So that was a huge bit of information for us to use going forward.
Thanks, Stacey. Just on that, could you tell us a bit about what you've done with what you heard and how it's shaped what you plan to do next?
Sure. So obviously we've highlighted that the main thing to come out of this was the difference between what the patient held as being important and our focus more on the kind of logistic side of it. So we already knew the approach was successful, the data did show that, but the conversations highlighted improvements that we could make along the way with further small change ideas. And actually the patients themselves had actually contributed to that, which was brilliant. We were getting it straight from the person that mattered the most. And the improvement that we come up with, and it's really quite small and probably blatantly obvious when you think about it in hindsight, was to come up with a template. Now, this would give essential information about the patient, times, what they were there for, where they'd come from. That would then be shared with the receiving nurse and the reception at the practice that we're going to attend their appointment in. And that made sure that the successes that we'd heard about, which were unintentional, I suppose, from our point of view, were continued. And to shape what we'll do next, the aim would be to replicate this fantastic experience from this patient across the service every time.
Brilliant. Thank you very much for that, Stacey and Alice, for your contributions there. I think those examples really do bring the patient experience and CEIM to life. But that's the end of our section. I'll now hand back over to Peter.
That's great. Thank you very much, Kieran and Alison and Alice and Stacey. That was really, really interesting. And I think just being able to go from those very big scale themes that Marianne was talking about to being able to operationalize that in a very practical way has been really helpful. We're going to have just a short time for some panel discussion now. So I think we're going to be moved over so you can see the speakers. So first of all, I'd just like to pick up on some of the comments in the chat from the video. Have a comment, how can this be in 2025? I feel quite saddened after watching the video. So true, that's why I run over all the time. Thought-provoking, quite a lot for a patient who's already struggling to deal with. Very emotive, really poignant. A comment from Canada saying there's the same issues there. This video was a realistic view of the real challenges I find. So I think there's a real sense of connection with that video. I'd like to just ask the panel to reflect on those comments and also on the little poll we had at the start. The top words that came up very much coincided with what the video said. Disjointed, inconsistent, frustrated, continuity, communication. I just wonder if each of the panel members had any thoughts or reflections on that little poll and how people feel about patient experience. Maybe starting with Marianne.
Yeah, I think it's real, and I think that's great. I know. I guess I'm someone who's always got a bit of hope, but we can't get better until we actually are honest about where we are. I've sat in too many sort of policy discussions or maybe kind of high managerial discussions where people talk about, oh, we're doing all this person-centered care, and I'm looking at the system and I'm looking at people falling through all the cracks. I think we can't improve things until we're honest about where we are. But I also get that sort of sense of, because there's so much. But I think what's really lovely about the guys sharing from their PCIP experiences, yes, there's a lot, but you can do a little bit over that little bit that you've got control of. And I think it's managing that tension of recognizing things aren't working, but also recognizing that you're not wholly helpless within that.
Thanks, Marianne. Stacey and Alice, did those comments reflect things that came up in your discovery conversations?
I would say definitely, particularly continuity. I think as nurses as well, we're always thinking continuity of care. As long as that patient's still seen, that's great. But actually what this did is throw up continuity also means the staff member that you see, the location that you attend as well. So it's definitely given us food for thought for the future with planning any changes.
Thank you. Alice, did you have?
Yeah, I would agree with Stacey. Continuity seems really huge to patients. Being heard seems really huge to patients. I remember years ago reading a research article when I was still working as a midwife, and it was called Leaflets, 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 See You Next Week. And I think that kind of can come across as how we work sometimes, unfortunately. So I think, yeah, I think that a lot of things that were captured in that are reflective of health professional and patients' experience of the healthcare system, and it's a bit frustrating from both sides because everybody wants it to be better.
That's great. Thank you, Alice. So we have a question that was submitted before the meeting, and I'm going to direct it to you, Marianne. It says, what are the points at which patient experience can meaningfully impact primary care improvement? So I guess my reading of that question is kind of what's under our control, because it can feel a bit overwhelming.
Yeah, I think it can. I think probably first of all, the sort of kind of recurring theme of this afternoon is finding ways to get feedback, not being afraid of feedback. My personal experience has been that actually people are very understanding of the fact that the health system is under a lot of strain. And while we might not want to be criticised because we're all working really, really hard, actually having an attitude of wanting to understand, people tend to be reasonable in their feedback, and they're not expecting you to fix all of that stuff. And sometimes it can, having those conversations can highlight things where you think everyone's understood what's going on and people think they've just been rejected. I think the other thing is looking at the referral process. So I'm aware there's lots of different services here, not just general practice, that's having a think about how people get into your service, and actually are there things that we're maybe doing that we maybe don't need to do, or are there things that we're doing that are maybe reasonable, but actually there's a particular population, for instance, people who don't speak English, who are never going to get through this system. So do we need to look at something tailored for them? And I think that sort of capacity and work paradigm is quite helpful. Are we, and particularly the work thing, because that is very much in our professional control, are we just lazily giving out work to people without really thinking it through? It may be, and again, there's differences in our population. Actually, somebody who, like me, who's young and has a car, well, I'm not that young, but young enough, got a car, I'm mobile, I'm zooming about the place anyway, I can sort of fit in a blood test, that's no problem, versus some of our more elderly patients who I feel are sort of like being called in for bloods, and then they're called in for an appointment at their different times, and actually every time they come down they need to get a relative to help them, or they need to get a taxi. So yeah, looking at can we bundle things up? Yeah, and in an ideal world, how do we work better together? Or when these things come up, how do we work together to sort of improve the system for the next time? Just a couple of thoughts.
Yes, thank you, Marianne. Especially struck by your phrase, not to be afraid of feedback, and the importance of being honest where our starting point is. I've got another question that come up. I'm going to direct it to you, Stacey. It's around the practicalities of listening to that feedback, and in particular, people have busy, complicated lives, as Marianne and the video both have explained and made clear. Do you have any tips as to how you maximize sort of people taking part or getting people to get involved? So how do you maximize kind of uptake given all the other pressures that people have on them?
So we've used the discovery conversations in two sort of different scenarios. The first one was in our hub setting, and just quickly, this is kind of overspill, if you like. Various different practices feed into the hub on certain days of the week, and we were just interested to know how patients felt about attending there versus their normal practice. And with that, I think Claire's already popped in the comments there, we aim to do 6 conversations a month. Now, we were quite lucky in that we done this in teams of 2, so we could dedicate that. So we didn't see the patient for their appointment, we just seen them for the conversation, and we just asked anyone that was in that day, would they be willing to take part, and we were able to get enough uptake that way. With regards to the wound care one, we done it slightly different because we were gathering this to go with data. We asked the patients in advance, when you were attending your next appointment, would you mind having a wee chat about this? We're really interested in your thoughts and feedbacks and improvement ideas that we could do to make this easier for you going forward. And again, because it meant they were continuing that treatment and they weren't missing out on, say, compression banding or whatever, they were really up for that, and with some really good ideas, some really good feedback from those conversations. So 2 kind of slightly different scenarios, but both successful in their own right, I would say.
That's great, thank you. And it was going to where people were. I guess it highlights as well that the people who weren't there weren't able to take part, and the importance of having that sort of wider understanding from the likes of Marianne's research to bring in the voices of people who aren't in the service to try and understand some of the barriers that stop them getting there. But thank you for sharing that. A question for you, Alice, is really around do patients get to find out that they've made a difference? How do you feed back to them that what they've shared has had an impact?
So here in the Borders, we're still quite early in our CEIM process, but we're planning how to share information back. We've done a few interviews just so far. We are thinking we'll probably put something on our website. We do have something on the NHS website about the CTAC service, and so we want to maybe put in a section with lessons learned and feedback and changes that we're making, and then we can direct people. I mean, it would be open to the public generally in the interest of transparency, but we can also direct people to that and say you can check in and see on that. And with other groups and so on that we engaged as part of the process, we always give them feedback and sent through any changes we were making to them so that they knew.
Right, thanks, Alice. And I guess it just really highlights that there's nothing more disenfranchising to be asked to contribute your experiences, which can be quite challenging for people, and then to feel that they've been roundly ignored and it was just a token gesture. So I guess we'd all agree there's better not to ask for experiences than to ask for experiences and then ignore them or make people feel they've been ignored. Just one final question to kind of wrap up this discussion section. And I'm going to just ask all of you, and I'll maybe bring you in, Kieran, as well. What is the single practical step you might take in primary care in the year ahead that you think would have the most impact on improving patient experiences? So Kieran, do you want to give us a thought on one single step that would have an impact?
Yes, yeah, I think the single step that would make the biggest impact is creating space for teams to regularly reflect on patient experience. It doesn't have to be overly complicated. It can just be short, structured conversations using something like CEIM as we discussed, because this can help turn everyday feedback into just small improvements. But over time, those small improvements do add up, and they really do shape how care feels, and it helps to give patients a real voice in how their care is presented to them.
Thank you, Kieran. That sounds really practical and doable. Can I bring you in, Stacey, with the same question?
I kind of have to agree with Kieran and improve that communication. I think we've personally gathered lots of great feedback and information from our patients, and it's about communicating that back. The proof is in the pudding, if you like. Here's what you said, and here's what we're going to do with it. So,
thanks, Stacey. And Alice?
I guess just trying to normalize patient experience and the time it takes to do it. I do think that it can be really seen as a bit of a tick box exercise. You know, we've got to go out and have done this. And it is the first thing to drop off because all of our services are overstretched and it becomes a thing that we have to cancel meetings for to do something else. And so I think really seeing it as something that's not a nice to have, but like we really need to be doing this and building it in would be my.
Thank you, Alice. And Marianne?
I think really focusing on how we can build our, I guess for me, practice systems around relational care and around continuity. And obviously we've got sort of continuity of care as part of the equity sprints of sort of starting to make those small changes of how you prioritise that as a practice.
That's great. Thank you very much. I really just want to, on behalf of everyone, thank the four of you for your contributions. We could have had a whole afternoon on this. It's such a huge topic, but I feel like you've broken it down and made it really accessible and also very, very practical. The main takeaways for me, I think, have been not to be afraid of this, to be willing to be honest about where we're at, but also to be able to build this in so that the patient experience is built into how we work, and also to then turn that into practical real life improvements, small things that make a big difference to patients, which are very doable and under our control, and I feel like you've highlighted some of those as well. So thank you very much for that, and I hope this has been useful. Would just like you to take a minute, if that's okay, to reflect on the insights shared, and to take part in the poll that's coming up now, in terms of how helpful the session was and any sort of key learning or improvement ideas.